This is a 67-year-old physician with an obvious congenital posterior polar cataract. And he's noticed increased difficulty with his acuity. Presumably, the polar opacity has enlarged recently. We don't have any evidence because we don't have any previous examinations, but he may have developed some posterior capsule opacification adjacent to it, or expansion of the lesion just by the fact that sometimes they do get bigger with time. So our plan here is to remove it and to place an intraocular lens, and of course, all the time being cognizant of the fact that approximately 1 out of 3 of these eyes have a congenital opening in the central posterior capsule underneath the opacity. If that's the case, it may be impossible to place the intraocular lens fully within the capsule or sac, and we may need to go to a sulcus lens, and preferably with optic capture. So the size of the capsulorhexis is going to be important here. We want it not so large that we can't capture, and not so small that capture is very difficult. As the video begins, I've made a side port incision here, and now the 2.4 millimeter clear corneal entry. And I'm going to inject some trypan, first some air and then trypan, so that I can always see this rhexis even if I happen to have that posterior subcapsular opacity in the way. That's some lidocaine. You can see the iris is a little bit floppy there. And now I'm going to inject viscoat and fill the anterior chamber and either expel or move these air bubbles to the periphery. So now I'm going to make an incision after I inject some Provisc in the anterior capsule, and it's difficult to see the opening there, but here we can see that with the trypan, we're going to wet the cornea here, see a little better, that with the trypan, we actually can see that incision, if you will, in the anterior capsule. So now let's create the capsulorhexis. An option is to do this with a femtosecond laser. Here I've elected to do it manually. I think the edge of the rhexis is a bit stronger manually than sometimes it is with a femtosecond laser, and when capturing, the strength of the rhexis is an important consideration. So here we go, somewhere around 4.5 millimeter rhexis, and that completes it there. And yeah, I like that size. So next we want to do hydrodelineation. That's a 27 gauge cannula, and I'm kind of wedging it into the peripheral nucleus region and then injecting. And now we can see the outline of the nucleus, but let's try and get a little more delineation, a little more fluid in the interface here. So I'm kind of going around and pressing into that area of the interface as I inject. And again, this shouldn't dislodge the posterior subcapsular opacity because it's the nucleus, not deeper. And going around here, that looks pretty good. Like we have a good outline of the nucleus there, and maybe a little more over here, a little more injection. And yeah, I think we can get that nucleus out now. So that's the chopper inserted. Notice I have the IOP set relatively low at 50 here. Anytime one thinks that the posterior capsule could be open, it's a good idea, I think, to use lower IOP and not stress it. So sculpting a bowl here, and now I'm going to chop. And the thing here is probably to remove each nuclear segment as soon as we make it. So I've got a segment up here, so I'm just removing it. So now I've increased the flow in vacuum to 42 cc's a minute and 600 of vacuum, but I've left the IOP at 50. Again, I want low IOP, and the handpiece that I'm using, the system, can handle low IP and high vacuum very well, the Centurion system here. So we've got more of the nucleus out now. Not a very dense nucleus. So now we're going to go after the epinucleus, and here we're going to have that posterior opacity come with the epinucleus, and we're going to find out if we've got an intact posterior capsule or not. Now let me say at this point, it may be intact, but it could still be very weak. They can be just, ridiculously thin. So if it's intact, and so far I think it is, but if it's intact, we don't want to shallow the chamber and stress the posterior capsule. So I'll show you what we do about that in a minute here. Yeah, a little ultrasound, remove that opacity, and we're good. I'm going to now inject OVD while I have maintained the anterior chamber foot pedal position 1. And as I inject the OVD here, and I get some in here, there we go. Now I'm on foot pedal position 0, and I'm filling the posterior chamber with OVD so the posterior capsule will stay back when I come out of the eye. I'm going to put a little more OVD in here now, right on top, and I'm looking at the posterior capsule and it looks fine. I'm not rubbing it. Don't do that in these eyes. You can open them real easy. So onward, irrigation, aspiration of cortex here. Now I'm bringing that cortex out. Subincisional cortex. No more difficult to remove in any other eye. Rest of the cortex being removed. And yeah, let's now remove some subcapsular epithelium. A little vacuuming here. Now the same thing, when I'm done doing this, I'm going to inject more OVD and maintain this chamber. I just don't want to see the posterior capsule come forward. It's a little tricky, this maneuver with your left hand and that big syringe, but practice it a little and it's certainly doable. So now we've got a nice chamber and we're up to IOL insertion. So here's our IOL injected through the 2.4 millimeter incision. Right into the capsular bag is the plan here. No need to do capturing. If we were capturing, we'd be putting a 3-piece in the sulcus and capturing the optic posteriorly through the rhexis opening. Oh, there's our IOL. Now, I'm not going to go in with an INA tip and remove OVD here. I don't want to shallow the chamber at any point. So I'm going to do stromal hydration, seal the incisions, and then I'm just going to irrigate the anterior chamber and a bit of the posterior chamber if I can to get out OVD. And I won't get as much out as if I used an INA tip and went behind the optic. But I don't want to do that here. Again, no stressing of the posterior capsule permitted. Irrigating out OVD, and I'll do it a few times. When I come out here, the chamber's still okay. And here we go again. Same thing. Just irrigating the angle and centering the IOL there. And I'm going to put some myostat in here. I just did to protect against a pressure spike, since I know I do have some OVD in the capsule, perhaps behind the IOL or in the capsular fornices. So here's our final view of this eye with a congenital posterior polar cataract, the nucleus removed after hydrodelineation, and fortunately in this case, an intact posterior capsule, so we didn't have to do a vitrectomy or put a sulcus IOL and capture the optic, although we were prepared to do that if it were to have been necessary.